HIV virus is not new to us. It is one of the most deadliest viruses known to mankind. Before we knew what it was already with us. Before we knew how to halt it, it had already spread across the country. We are about to enter the fourth decade of HIV, and at this moment in time, it is imperative that we look back in order to look ahead.
HIV AIDS has been a medical catastrophe ever since it was first identified in June 1981 by the US Center for Disease Control and Prevention. Nearly 4 decades later, the world continues to face the human tragedy of HIV AIDS. This epidemic started to spread rapidly in 1980s and 1990s in Asia and Africa because of biological and behavioral synergies with conventional sexually transmitted infections. As of today, there is still no cure for HIV infection, no effective protection method, and no vaccine that is globally accessible.
Poverty, starvation, violence, no water, no education. But worst was yet to come, in the form of HIV AIDS. This was the most catastrophic emergency Africa and the world has ever seen. Poor countries had no access to the low-cost medicine, which would have saved their lives, and this was the only reason behind the death of millions of people suffering from AIDS. Dr. J. Levy began his studies on AIDS in the year 1981. He discovered AIDS virus HIV in 1983.
When this disease first appeared in San Francisco, it looked like a viral disease, and my group immediately began to look for the cause. This was in 1981, and we were able to isolate the virus in 1983, and were surprised to some extent that it was a retrovirus. We didn't know how it was transmitted, we didn't know what the type of virus it was, but it took us at least 2 years to join others in recognizing that this virus was spreading and was causing an epidemic in the world. Now, going to Africa and speaking with individuals like Dr. Hira, we knew that the drugs were expensive and that we needed to advocate universal treatment if it were possible, and that has, of course, come through. This virus enters and becomes part of the chromosomes of the cells. Therefore, in order to get rid of the virus in the body, one needs to eliminate all the infected cells. That can't be easily achieved with just using drugs. We now are looking at approaches through genetic editing to take blood stem cells and create an immune system that is totally resistant to HIV. That is achieved with the newest molecular approaches called CRISPR, where you can knock out the gene for the receptor of the virus, CCR5, and once that immune system repopulates the body, that person should be resistant to the spread and the cause of AIDS. We have achieved a great deal in the approach at controlling HIV and AIDS by collaboration from research scientists in academic labs and in pharmaceutical companies, reacting and working with clinicians and their patients. We've been able to permit in many countries individuals who are infected with HIV to have a normal lifetime. What we recognize is that that is expensive, and there are side effects of some of the drugs. That is why we are looking for a cure that would permit the person's own immune system to control HIV. We have been following, for example, some people, 35, 36 years, who have an innate immune response against HIV, and they don't need any drugs. It's encouraging because it says they have a genetic mechanism for controlling the virus, and we should be able to work on that and offer that to all infected people.
I've been involved with the AIDS epidemic from the beginning in the United States in 1981. In the late 80s, I was working internationally with a colleague of mine, Dean Palmer Beasley, And we looked at various countries. Because of the warm reception of Kenneth Kaunda, the president of Zambia, we elected to set up our program there. We received a large grant from the federal government in the United States to set up a research program there. That's where Dean Beasley and I first met Dr. Subhash Hira. We immediately established a relationship. Dean Beasley and I were impressed with Dr. Hira and his very important work in Zambia on community HIV infection. We felt that Dr. Hira was one of the lead scientists internationally working on the AIDS epidemic and wanted very much to work with him. After finishing our studies in Zambia, it was at a time when the AIDS epidemic had plateaued in Africa. And what was really striking to us is that the AIDS epidemic had hit India and the Indian subcontinent in a major way. Dr. Hira, Dr. Beasley, and I worked together in Zambia and planned the development of Archon in Mumbai. That program that we built was successful in promoting generic antiretroviral drugs, which was important to controlling the epidemic. Well, the AIDS epidemic and AIDS in general, I consider the most important infectious disease pandemic in the last 100 years. It is major, and we cannot forget it. We have to focus, we have to hit it hard, hit it fast, and get it totally under control. I believe that a vaccine will at one point be proven to be the most effective way to deal with this epidemic. We do not have a AIDS vaccine available at this time, but we know so much about the pathogenesis, the immunology of this infection, and I'm guessing within the next 5 or 10 years we will have such a vaccine.
The number of patients on hearts have increased from 8 million to 25 million. I think we need that type of Professor Ira. And then I think we support Professor Ira because of his plan on research. Only research can solve the problem. There is a lot of unclear problem on HIV in Africa. Professor Ira, he designed a really good program for prevention control for HIV and STIs. It was well designed by Professor Ira. Not only treating the patient, but he did something good that included the behavioral change and treatment and the partner management.
Former Zambian President Kenneth Kaunda helped creating awareness and raised funds for his war against HIV/AIDS pandemic in Africa. The spread of HIV. India's denial. The story of HIV/AIDS in India is one of denial and delusion. India didn't wake up to HIV/AIDS crisis until it was quite late. It was only when scientists discovered that HIV could actually be passed on through blood transfusion that it came as a shock to the health ministry here. But even so, India was shy to admit that there was a problem.
The challenge was to be able to convince the Indian pharma to be able to deliver and generate generic antiretroviral drugs at a very low cost, so that these will be able to expand on to the African and the Asian continent and the South American continent, to cover at that time 45 million people with HIV AIDS. That was something which took immense amount of coordinated advocacy using the various UN and developmental agencies. So based on the trust that the international leaders placed in me, I was able to design, develop, and coordinate with the WHO, Geneva, and the World Bank to be able to expand the outreach of antiretroviral medications to 3 million people by 2005, and gradually over years to now what is 25 million people by 2018. These people are able to now live with HIV AIDS, be productive and have a healthier life. We are glad that we have reached that level, but there is a long way still to go. In a recent article that I wrote along with colleagues is to look at the HIV AIDS epidemic in India and see what happens by 2030 and 2040. And the estimates that we have worked out as shows that the numbers will keep increasing from some areas that will get more attention to control to other areas which will be the newer epidemics emerging in different parts of the districts and states of India. With the present strategies, there is of control, prevention, care, treatment. We don't see the epidemic going down, but will probably plateau around 2040. Most of us who are the beginners of this, been with this epidemic from the beginning, that probably we would not see a solution to this HIV/AIDS epidemic in our lifetime. But I am hopeful, and so are my colleagues like Dr. DuPont and Dr. Jay Levy and Bob Gallo, that some point in time, while our lifetimes, we will see cure of HIV/AIDS.
When we had started prevention of mother-to-child transmission in 1998, at that juncture, myself and Dr. Hira met chairman of the Shipla Pharmaceuticals to impress upon them to start manufacturing of antiretroviral drugs of generic version to bring down the cost of the drugs. Telling them about the scale and the health system available in India to implement the treatment of HIV patients through the healthcare system in India. Chairman of the company, Mr. Hamid, was very much convinced with our explanation, and they agreed to manufacture generic version of the antiretroviral drug because of successful efforts of the program. Because of this effort made by the Shipla, the cost of the combination therapy was brought down substantially from 55,000 per patient to almost, we can say, rupees 5 to 6,000.
These are eminently fatal diseases. There is a need to promote and, it is lacking according to me. Patient gets affected with this disease, with this virus. It's not that just ART is everything. As I told you, right from marriage to illnesses, childbirth, sexual life, longevity, concomitant illnesses. There are many, many aspects. There's a continuous need to mentor young students. I am aware of some sexual clinics or sexual health clinics that exist in the developed nations. We don't see such things. So that's an area to work both from community medicine people. Most students, they do a lot of search on their own and by using Google. They still are left with some questions. So at some point, you need to come to the doctor. An element of confidentiality is there universally in healthcare. I mean, in all our training teaching, it's not only HIV. Confidentiality is a part of every patient doctor, every interaction that a doctor does. So, as I said, the only way out is one of the way out could be to look into the area of sexual health for the we have been looking at STD clinics only for patients who come after they develop a STD. So, but that is too late.
Women were not willing for testing. But the NACO has started antenatal surveillance in 97, and we at Nair Hospital participated in the study, and we reported the prevalence as 4.5%. That was the highest in India. Meanwhile, I was introduced to Dr. Subhash Hira, the professor in charge of Arcon at JJ Group of Hospital, Mumbai. Since the intervention was not supported by NACO, the Arcon supported intervention, and CIPLA gave medicine at a concessional rate, and that too had to be bought from the CIPLA office at Mumbai Central. The response was very irregular depending on the affordability and availability of funds with the patient. The drug was taken still irregularly because of shyness and stigma. NACO offered me to write a training module of 5 days for all doctors and nurses of government hospitals, and I wrote it within 6 months, and that was well appreciated and was implemented all over India. Challenges were that initially when women were admitted for termination of pregnancy, the doctor's attitude was different, nurses' attitude, IABI and ward boys were very different. Reluctant to give bedpan, reluctant to give them a proper food. Our resident doctors were also not willing for touching them and offering them services, and hence many patients were something asked to get discharged without giving a specific reason. And then I started a training module for IABI and nurses and ward boys too. Second thing, I found that our lab technicians and our ambulance drivers were not ready to take the patients in their ambulance, not ready to transport blood samples from one hospital to another. They used to throw away, and I used to get a report, sample not received. So I had to start a counseling and the training for drivers as well as lab technicians.
People basically were not knowing that there is difference between HIV and AIDS. So first thing is that they were thinking that when the word comes HIV means we are going to die. And that was very difficult to handle with. The stigma was there. And it was related to the moral or behavior, habits. That was like sexual diseases. It was related somewhere unnecessarily to that, which was not actually correct. But it took a lot of time to remove the misconception. Affected people are relatives of the affected people, and they have to cooperate. And I think so. Their contribution is tremendous, and that I actually always salute them, because to have a HIV positive person in the family and face it. Many times we are helpless. For discrimination, we are always vulnerable. So for that purpose, I fought, and I think I got the result. So what we are thinking nowadays is, today's scenario is better. Better means not like that. It is a generalization of the disease, which is very, very important. Means what? It is happening. I'll tell you one thing, that these people with whom I worked, I still have, in my eyes it reflects always, they're not selfish. भगवान ने भी नहीं दिया है उनको ये शिक्षा उनको किसने दिया, क्या दिया और क्यों दिया, वो अभी तक उनको पता नहीं, ना हमें पता है. That feeling is there now. That is very difficult to overcome. But they taught me how to overcome it.
This book by BBC director Daniel Lack lists heroes who changed India starting in 1990. Mukesh Ambani for private sector, demographer Dr. Bose for data analytics. Narayana Murthy, Nandan Nalikani for information technology. Prime Minister Manmohan Singh and Rajat Gupta for economy. Amartya Sen for Orissa famine. Chandrababu Naidu for infrastructure, Dr. Subhash Hira for AIDS and health. Red Cross and Care Organization for disaster management.